before we move on to the next part of this ECG, there is definitely a question to some students. They might be wondering, you got atrial depolarization, you've got ventricular depolarization, and then you've got ventricular repolarization. So where is atrial repolarization? I mean, there's an atrial contracting and there's a wave. You've got a ventricle contracting and there's a wave. Even when you have your ventricle relaxing, there is a wave. But what about atrial repolarization? Can you even find any waves which depicts that? Alright, good question if you have that. Now let me explain. Literally, if you go to find the wave which depicts your atrial repolarization, you would actually find them in this QRS complex. Like, yes, QRS complex. Y is basically ventricles as they contract. Okay, so basically both your atrium contracts and then it leaves a space and then it relaxes and then the blood fills into the ventricles and then your ventricle starts contracting and then it relaxes again, right? So as you know, your ventricles are way tougher and stronger compared to your atrium because the amount of volume that they need to actually hold into that particular cavity is actually way bigger compared to your atrium, right? So as your ventricle actually contracts, it masks your atrium relaxation. Okay, because the simple interval in between your atrium relaxation and the ventricle contraction is literally very, very small. All right, so what happens is as your atrium relax, it is being masked by the tough and strong contraction of your ventricles during at the phase of your ventricle depolarization. So that small peak is basically is masked with your atrial repolarization. So therefore it's actually embedded in between into this particular interval, and that is why you really can't view or see your atrial repolarization wave, right? So I hope that you understand this part, and let's move on to the number of boxes. Okay, so as you see your ECG strips, literally you'll get to see a big box like this. Okay, but literally have a numerous box like that. So you will have 5 boxes in for 5. Okay, so excuse my drawing again. So yeah, so you have like this, isn't it? So you got one small box which is actually equivalent to 0.04 seconds, and then you've got a big box so which contains 5 boxes in. So you got your 5 times your 0.04 is basically 0.2 seconds. So one small box is 0.04 and then one entire big box is 0.2 seconds. Okay, so this is the simple thing that you literally need to know about the number of seconds, because this is what you'll be using to actually calculate the intervals in between and even your QRS complexes and all that. Okay, so now how do you interpret your ECG is I will teach you a simple 6 to 7 steps. Okay, so step number one is you need to calculate the heart rate and you need to check out the rhythm of your heart. Okay, and number 2 is where you check out the cardiac axis. Okay, the cardiac axis, which is where it shows you a right axis deviation or even a left axis deviation or a northwest west axis, or also known as an indeterminate axis. And then you have few normal axes. Okay, so I'll be going one by one, so keep calm. And then step number 3 is where you check out how your P waves looks, whether are they absent or they're present, are they flattened or they're upright, okay, or they're peaked. It literally shows the difference, all right? And then you've got step number 4, which is to check in between. So once your P is done, okay, you've calculated the heart rate and then you checked out the rhythm and then you check out the cardiac axis and then you look at your P waves. So once you've done looking at your P waves, then what you do is you look at your interval, which is your PR interval. If they are constant or if they're prolonged, it makes a difference. And then you go to your step number 5. So step number 5 is where you have your what? Your QRS complex, which is your inverted V here. Okay, so how does the QRS complex look like? All right, and then you look at step number 6, which is where you get to see your ST segment. So in between your ST segment, how do they look like? Are they depressed? Are they elevated? So usually this ST segment is related to how you diagnose myocardial infarction. Okay, so you've got 2 types, which is your ST segment depression MI, and then you have your ST segment elevation MI. We'll move on probably in the next talking about, if let's say I'm going to do a topic video on MI, then I'll be talking about it in further, right? And then you got step number 7, which is actually the last segment, where you look at your T waves, if they are peaked or if they are flat or if they are depressed. Okay, T wave, and also a U wave. Okay, so literally if you look at U wave, in a typical normal heart patient, you don't literally look at a U wave popping in. And U wave is basically an abnormal wave where you get to see them all of a sudden popping in right after your T waves. Okay, and that is actually related to some metabolic abnormalities. Okay, and I'll be talking about it as well. So these are the simple steps that you need to actually follow to interpret ECG. It's literally easy. Okay, so you've got first your heart rate and your rhythm, and you look at your cardiac axis, and then you look at one by one your P waves, and then you look at your PR interval, and then you check out your QRS complex, and then you look at your ST segment, and then you check out T waves. And let's say if you see somebody with the name of U popping in, and then you look at these U waves as well. Now let me go one by one. So talking about your heart rate and rhythm, how do you actually evaluate or calculate your heart rate rhythm? So as I taught you, this part makes a very important vital role here. And this literal small boxes here would make you actually to calculate your heart rate. Now, to calculate your heart rate, first you need to look at how regular your entire strip of your ECG may look like. If let's say your entire rhythm is regular, okay, so before that, heart rate can be actually calculated using the following method. Okay, and you got to know, you got to see them if they are actually regular or irregular. And how do you know if they are regular or irregular? Okay, so you have a heart rate, an ECG strip like this, your P waves, and then you've got your QRS complex, and then you got your T waves, and then you got it normal back, and then you get again your P waves, and then you got your QRS complex again going in, and then you have your T wave, and then it continues all over again. So what do you do if let's say if you get a long strip, right? So if you see the wave being continuous like this, so what do you do is basically to calculate your R waves is where you use the interval of your R to R. So literally what you do is along the strip you get to calculate the entire R to R intervals, okay, and then look if they are regular. So the number of boxes in between your R to R interval, every R to R interval will show if it's regular. So let me show you an example. If let's say from R to R you have 4 boxes, okay, four small boxes, right, small boxes, and then from this R to another R will be another 4, and then 4, and then 4, which means this is a regular rhythm. So in case if you have a regular rhythm, what do? Is you use a formula of your heart rate, which is equals to 300, okay, divide by the number of boxes in between your R and R interval, in between your R to R interval. And this formula is only used if the entire rhythm is regular. How do you know if it's regular? Your R to R interval should be same in every R to R interval. But let's say, so for an example, if you get 4 boxes, so 300 divided by 4 is 75 beats per minute. So which means the patient is having a normal heart rate of 75 beats per minute. And if it's regular, then you will just say that the rhythm is regular. So if 75, the patient is not tachycardic or brady, he's in a normal beats per minute. So 60 to 100 is a normal heart rate, correct? But let's say if your entire rhythm is irregular, and how do you know if it's irregular? If you get a 10 seconds long of your ECG strip, okay, you can't be using the same formula again for an irregular rhythm. Why? It's because the R to R interval is not the same along that 10-second strip. So what do you do is, if let's say you've got a long strip like this, okay, and literally you have your, okay, all your, sorry, I'm really sorry, I just got to be fast, okay. So what do you do is, if you literally see that they are not literally regular, correct? So what do you do is count the number of QRS complexes along the 10-second strip, okay. So for an example, if let's say during this 10-second strip they have 10 complexes, okay, 10 complexes, so these 10 complexes will be multiplied with 6. So if let's say the patient has 10 complexes, you times it with 6, you get 60 beats per minute. So this is in the lower limit of a normal heart rate. So 60 beats per minute is still considered normal, but probably in the lower limit. All right. So let's say if the patient has 15 complexes along the 10 seconds, so 15 times 6. All right. So you get around 90 beats per minute. So 90 beats per minute is still fine. Right? So this is how you actually calculate if the patient has an irregular heart rhythm. So how do you know, how do you define if the patient is having a normal heart rate or a tachycardia or bradycardia? A normal adult heart rate is, as I told you, it is 60 to 100 beats per minute. If let's say the patient is more than 100, okay, this is specifically for adults, all right? More than 100 is known as tachy. Oops, sorry about that. Okay, tachy. And let's say if the patient is less than 60 beats per minute, then it is bradycardia, which means it's a slow heartbeat and this is a fast heartbeat. Okay. Now, another hint here is you've got to also check on, looking into the heart rate. You need to know if the patient is having any AV conduction blocks, all right, your AV blocks. So it's really important to actually check on the ventricular rate and as well as the atrial rate. Okay, so if let's say if the ventricular rate and the atrial rate is 1:1, then you have a 1:1 AV conduction. But anyway, if it's confusing to you right now, then probably I will discuss this specifically in conduction system defect. All right, so this is basically your heart rate, and then you check on your rhythm. So I've told you on how does it look if it's regular, how does it look if it's irregular. But then if let's say if you have an irregular rhythm, your irregular rhythm can be regularly irregular or irregularly irregular. Okay, don't get confused, because both of them is definitely not the same. They are totally different. And what does it mean is basically, as I told you, you've got a regular rhythm. And how do you know if it's regular? By checking on the R to R interval. And let's say if you have an irregular rhythm, then which means the R to R interval is not as same throughout the entire 10-second strip, right? Or probably the entire strip as well. So an irregular rhythm can be divided into regularly irregular, which means they are literally irregular regularly. Or an example is a recurrent pattern of irregularity. They are literally the same, being the same but irregular. But if let's say irregularly irregular, which means they are completely distorted, completely disorganized. Okay, so in this kind of case, what do you do is again, if you need to look at you need to mark out the several consecutive R to R intervals. Okay, and then you need to move them along the rhythm strip to check if their subsequent interval is same. Okay, the subsequent R to R interval is same. And again, a small hint is, let's say if you suspect that there is some AV block, because as you know that in your AV block you might have your PR interval to not be constant, right? Some of them will be prolonged, some will be constant, some will be totally distorted, running on its own. Your atrium start pumping its own, your ventricle starts pumping its own, right, contracting its own. So what you do is you need to really mark your P waves and your R waves, which means you look at your atrial waves and your ventricle waves. Okay, so your P waves and then your R waves, and then you need to check along that PR interval along the strip. If their PR interval is it's constant, then it's fine. Okay, which means probably it could be regularly irregular. But let's say if your PR interval there's changes, and all of a sudden you see a drop bit of your QRS complex, which means your entire QRS complex misses along the way, then there is a complete dissociation between these two. All right, so this is where you have your heart rate and your rhythm. So you're done. If you're clear with this, let's move on to step number 2. So in step number 2 is where you need to look out for your cardiac axis. Now, what does it mean by cardiac axis? Okay, if you look at this picture, you have your right leads, your left leads, and then your leg leads, which is your foot leads. And then you have lead 1, lead 2, lead 3. Now, basically, your normal cardiac axis is basically describing the overall direction of electrical spread within the heart. Okay, so in a healthy individual, the axis actually should spread from, okay, your AVR, okay, towards this side. So it starts from your right to your left, goes this way. So in a simple way, it's literally from like 11 o'clock to 5 o'clock. This is a normal way of how your electrical activity should spread along this axis, correct? So to determine the cardiac axis, you need to look at, sometimes some say that you look at lead 1, lead 2, and lead 3. Okay, some say that it's better to look at lead 1 and AVF. Okay, so it's up to you. It's up to you on which type of which axis that you would like to look at. So as I told you, a normal cardiac axis is from your 11 o'clock. It spreads this way. Okay, it goes this way. So as you can see, since it starts from here and it goes, the positive deflection is way stronger over 11 o'clock to 5 o'clock, so it's stronger at this. That is where you literally see a positive upright QRS deflection over this area. However, as it reaches towards 0, it's being into a normal axis where you don't really see much deflection over here. Okay, so since it's starting at your negative degree, because your electrical spread is starting from here, your 11 o'clock to your 5 o'clock, so you literally don't see a positive deflection because it starts here. It starts from 0. Okay, so it starts from a negative deflection. You get a negative QRS complex, and then as it spreads over to the 5 o'clock, and you see the strongest positive deflection is at lead 2. Okay, so this is normal. This is where you can find in a normal healthy individual. So literally, if you look at the axis of lead 1, lead 2, lead 3, if you see the lead 2 having the most positive deflection compared to lead 1 and lead 3, then this is normal. It's fine. So again, talking about cardiac axis, as I told you, the types of cardiac axis we have is the normal axis, which is found in healthy people, and then you have your RAD, which is your right axis deviation. Then you have your LAD, which is your left axis deviation. Then we have the northwest axis, which is actually indeterminate. Okay, indeterminate axis. And then yeah, your normal axis, right? So we've already discussed how a normal axis will look. Usually it starts spreading from 11 o'clock to 5 o'clock, and the most positive deflection is seen at your lead 2. And if let's say you have a right axis deviation, so if right axis deviation, as you can see, is going from right to left, so if it's deviated, if there's probably, for an example, this right axis deviation happens due to causes of right bundle branch block, right ventricular hypertrophy, so which means there's a scarred muscle, cardiac muscle, over that right and over that particular right side of your heart. So what happens is they literally don't get spread over there, so they get deviated towards the right side. Okay, they're supposed to go here, but then they start ending up probably this side or probably this side. So as you can see, when you compare your lead 1, usually we will look at lead 1 and we will look at AVF. All right, so what happens is, if the QRS, okay, so you look at the QRS complex in lead 1 and AVF. If the QRS complex is predominantly negative at this side, okay, which means you see your inverted QRS like this. Okay, and then if you look at AVF, if there is a positive deflection, so if you can see, they are literally meeting up together like this. Okay, your lead 1 and then your AVF, you see them literally kissing each other, then you find this right, so it becomes right axis deviation. Okay, and as I told you, the several causes of what causes right axis deviation is basically your right bundle branch block, your right ventricular hypertrophy, sometimes even dextrocardia. Dextrocardia means your heart is supposed to be in the left side, but what happens is your certain people have their heart formed at the right side. So therefore, you have the electrical activity to spread along your heart more towards the right side. All right. So these are the few causes of right axis deviation, and left axis deviation is just the opposite of right axis deviation. So what happens is, in right axis you see them both kissing each other. Okay, but in case of so this is RAD. So in case of LAD, what happens is you literally see them moving away. Okay, so you have them in lead 1, the QRS complex in lead 1 will be facing upwards, which is positive, and then you see the AVF is being negative. So literally they move away from each other, so they left each other, in another word. Okay, a simple way of remembering, they literally left each other, so therefore they are left axis deviation. And the causes of LAD are usually just the opposite of RAD. Okay, you have your left ventricular hypertrophy, you have your LBBB, right, and even sometimes myocardial infarction and all that also can be seen, okay, with the left axis deviation. So you are done with your second step, the cardiac axis, right? This northwest axis is actually not really seen. They are basically indeterminate. Okay, you can't really classify them into any deviations. Okay, so most now commonly you see a normal, your RAD or your LAD. Okay, and then you have your P waves. So looking into P waves is where you look at this little hump over here, which is your atrial depolarization, where your atrial starts contracting. So there are few things that you need. So you're done with 1, you're done with step 2, and then you look at P waves. So first thing that you need to look at P waves is, number 1, you need to check if they are present. Okay, so if they are present, then fine, you just need to say that P waves are present or P waves are absent. Okay, if let's say they are present, then you need to check on if these particular P waves are followed by a QRS complex. By right, every P waves need to be followed by a QRS complex, but sometimes every P wave will have a drop bit, which means they don't even have QRS complex, and you see them in conduction defects. All right, and then you need to look at the P waves if they look normal or not. So you need to check on the duration of the P waves, if they're if they're lengthened, if their P waves are so much lengthened, they look more flattened. Okay, their shape, sometimes they can be upright, they can be peaked. Okay, and let's say if they are not present, sometimes you can't even look if the P waves are even present or not. And usually P waves they are not present in certain kind of atrial activity, which means each time your atrium contracts, you get this bit. But sometimes when your atrium starts contracting very quivering, right? So you start seeing a flutter waves, or sometimes a sawtooth baseline like this, like this P wave. So literally you can't even find which are even your P waves, and this is literally seen in atrial fibrillation. Okay, which means your atrium starts starts having a quivering wave, right? Okay, so basically this is how you look at your P waves, and then you go to your PR interval. So done with step 3, then you go to PR interval. So looking into your PR interval, which is between your P to your R, okay? So a normal PR interval should at least be around 120 to 200 milliseconds. Or in simple ways to remember, it should be around 3 to 5 small squares. This is normal. But sometimes when you see your PR interval is present, then you need to calculate the amount of boxes which is in between this PR interval. Okay, then you need to look that if this patient, this particular patient has a prolonged PR interval. So if let's say a patient has a prolonged PR interval, which means there is a block after your AV node. Okay, which means there's an atrioventricular delay. As I told you, SA to AV node, but what happens is there's actually a block over this area, so your atrial have already contracted, okay, but then before it reaches your ventricles to start contracting, there is a cut, there's a block, there's a delay. So what happens is you literally see it takes your P literally takes some time before it starts having a ventricular depolarization. So you need to measure the amount of boxes in. If let's say the patient has a PR interval of more than 0.2 seconds, right, which means the patient is having a prolonged PR interval. Okay, so this is where you need to check on if the patient has a first degree heart block or a second degree heart block or a third degree heart block, and all this will be mentioned in my probably another video. Okay, I don't want to literally waste my time here. Okay, so let me move on to next will be your QRS complex. Yeah, okay, wait. Another thing is I've missed here is we've talked about prolonged interval, and then some would also have a shortened PR interval. So if let's say the PR interval is short, okay, so this means one of two things are happening. Simply the PR waves is probably originating from somewhere closer to the AV node, so that the conduction actually takes less time. So which means normally if a patient should have 120 to 200 milliseconds, okay, from after the contraction, and then your ventricular contraction, your atrium contraction, your ventricular contraction. So in between your PR interval should be 3 to 5 small boxes. But what happens is if let's say they have a shortened PR interval, which simply means that your P waves is somewhere originating closer to the AV node. Okay, it's the distance between both the nodes are probably closer to each other, so it takes a lesser time for what do you call your ventricle to actually starts contracting. So once your atrium contracts, and then automatically your ventricle contracts. Okay, or it could be that your atrial impulse is getting to the ventricular by a faster shortcut of conducting slowly across the atrial wall. So probably maybe they've already found an accessory pathway. Okay, maybe here. So what happens is they literally form an accessory pathway, and they start firing the impulse faster. Okay, so in this accessory pathway, you literally get to see the patient having a delta wave, so which means a P wave, and then they have a shortened PR complex, and you could literally see a sort of like a camel hump appearance here. So which means it takes a shorter interval. Your PR starts quickly here, your QRS complex starts quickly here. Once after P, they quickly form a delta wave like this. So this particular hump is known as delta. It's a delta wave, and usually it is associated with your WPW syndrome, which is your Wolff-Parkinson-White syndrome, where your in between your SA node to your AV node, there's actually an accessory pathway which is connecting a shortcut to your AV node. Okay, so this is all about your PR interval. And then you have your QRS complex. So we are done with PR, and then you have your QRS complex. So when you look at your QRS complex, first you need to find out if your QRS complex are absent or present, because sometimes they tend to have drop bits. Okay, or you need to look at the width of it. Okay, so which means normally you have a QRS complex width, and you need to look at how peaked it is, the height of it. Okay, and also the morphology of the QRS complex. Okay, so it's important to know to classify your QRS complex into a narrow or a narrow or a broad QRS complex. It makes a lot of difference, okay? And this is really very, very important in the conduction system as well. So when you look at the width, okay, you look at the width, you see if it's narrow or if it's broad. If it's a narrow QRS complex, it occurs when the impulse is conducted down the bundle of His and the Purkinje fibers to the ventricles. Okay, so which means when SA to AV node, it has already received, and now it needs to pass it to the bundle of His to the Purkinje fibers. So if let's say a patient has a narrow QRS complex, okay, P, and then you have a very, very, very narrow QRS complex like this. So which means that the impulse is conducted down to the bundle of His and Purkinje fibers to the ventricles. So this results in a well-organized, synchronized ventricular depolarization, which is actually sort of normal, all right? But to say normal, they're not really normal, but they are still considered a well-organized, synchronized ventricular depolarization. And a narrow, what do you mean by a narrow QRS is basically, they are less than 0.12 seconds, okay? If let's say they are broad, so you've got a P and then you see a broad QRS complex like this. So which means they are more than 0.12 seconds. So a broad QRS complex occurs if there is an abnormal depolarization sequence. For an example, probably you have already found a ventricular ectopic where the impulse spreads slowly across the myocardium from the focus of ventricle. Okay, so which means by right the SA to AV node and goes to the bundle of His, but instead of going to the bundle of His, probably it forms another ectopic bit somewhere around. So this ectopic bit sometimes results from a scarred scarred myocardium, okay, or cardiac muscles. So this will sort of form another accessory pathway which delays the ventricular contraction. Okay, so in contrast, in atrial ectopic, even sometimes if a patient has an atrial ectopic, probably from your SA they form another ectopic beat, okay, an ectopic pathway. So even an atrial ectopic would also result in a narrow QRS complex, because why? Your specific atrium, as it starts contracting, because it would conduct down the normal conduction system of heart. Okay, so basically this is what you need to know regarding the width of the QRS complex, whether they are narrowed or they are broad. Okay, QRS complex. And then you need to look at the height. You need to know if, let's say, the height, the specific height of these QRS complex are small or tall. So small complexes are actually defined as less than 5 mm in the limb leads, okay, or less than 10 mm in the chest leads, okay. And tall complexes, which means if I say you literally see a very big tall complexes, which means the patient is implying a ventricular hypertrophy, all right. But sometimes if let's say patient has a very, very tall every tall complexes does not really imply ventricular hypertrophy. Why? Because some patients, like tall sleep people, like muffinoid patients, can have a very tall QRS complex, because it depends on their body habitus, okay, so which is actually a normal thing to them. Alright, and then you need to look at the morphology of your QRS waves. So example of morphology, as I showed, is like you need to look at how is the morphology of the QRS. Well, first thing is if they are upright, and then do they have a specific delta waves here? So if they have a delta wave, which means they show a WPW syndrome. So this is with QRS complex. So you have already checked with the width, you have checked with the height, and you've checked with the morphology, WHM. Okay, and once you're done with your QRS complex, then you need to look at your ST segment. So looking at your ST segment, I think I've already told you what does this ST segment mean. Once your QRS ventricle have contracted, and then between your S to T is basically your ventricular relaxation happens. So if let's say in between there is a depressed ST segment, or probably an elevated ST segment, would actually show myocardial infarction. Okay, so done with ST segment, and then you need to look at your T waves. So looking into your T waves, you need to again look if it's present or if it's absent, or sometimes you need to even look if the morphology of the T waves by itself, if they are flattened or if they're depressed, or if they're even pointed, pointed T wave. And usually these pointed T waves are actually associated with hyperkalemia, metabolic abnormalities. All right. Or sometimes you have a very freaking tall T waves, which could even show an hyperacute stemmi as well. Okay, and then once you look at your T wave, then you need to look right after T waves, you need to actually look at U waves. So sometimes people really get confused, like after T wave you get to see a small hump here. So is this literally P wave or if it's a U wave? Usually a U wave is way smaller compared to P wave, and then sometimes this U wave will be followed they do not follow a QRX complex. Okay, however, P waves, once after P wave you literally have a QRS complex, but a U wave will not follow after will not have a QRS complex following after a U wave. And this U wave is also associated with specific metabolic abnormalities. All right. And basically you can see a classical U waves in an electrolyte imbalance, as I told you, or sometimes even hypothermia, or sometimes when you start giving the patient with too much of anti-arrhythmic therapy such as digoxin or procainamide or amiodarone, you can even see this U wave starts having a deflection of more than 0.5 mm after the T wave. So this is actually the presence of the U wave. But however, this U wave is not a common finding that you can see in ECG. So this is basically a simple video that I have done. I know that I've really spoken a lot, but let's recap again. You have simple 7 steps on how to interpret an ECG. You have, first, you need to look at your heart rate. To calculate the heart rate, if it's regular, you need to divide the number of R to R interval, which is the boxes. So 300 divide by the number of boxes. If it's irregular, if it's a 10-second strip, calculate the number of complexes and times with 6. Okay. And also you need to look out for any AV blocks to look if they are prolonged or they are constant and all that. Then you look at your cardiac axis. You need to check of RAD and LAD. Usually RAD, they start kissing each other and they become right. So they start facing each other, they become right. So it's RAD. However, LAD is they leave each other. Okay, so which means they go on opposite direction. So that's LAD. And you look at your lead one and also your